Hi, and welcome to the lecture on cardiovascular emergencies. After you complete this chapter and all related coursework, you will have an understanding of the significance and characteristics of anatomy and physiology of the cardiovascular system, as well as specific cardiovascular emergencies. You'll understand the pathophysiology of respiration and perfusion, signs and symptoms of the most common cardiac conditions, the indications, contraindications, and use of AEDs, and general care of a patient experiencing a cardiac emergency. You should also be able to apply your fundamental knowledge to patient assessment and management during in-classroom scenarios. Regarding the National EMS Education Standard competencies for cardiovascular emergencies, for pathophysiology, you as a student will be able to apply fundamental knowledge of pathophysiology of respiration and perfusion to patient assessment and management. For medicine, you will be able to apply your fundamental knowledge to provide basic emergency care and transportation based on assessment findings for an acutely ill patient. For cardiovascular specifically, we'll review the anatomy, signs, symptoms, and management of chest pain and cardiac arrest, acute coronary syndrome, including angina and myocardial infarction, aortic aneurysm and dissection, thromboembolism, heart failure, and hypertensive emergencies. As we work through this chapter, the thing that you really need to remember about cardiovascular emergencies is that heart disease has been the leading killer of Americans since 1900, and it accounts for about 1 in every 2.8 deaths. So realistically, it's almost half. As an EMS provider and as an EMS group, we can help reduce deaths by providing the following services. We can encourage people to follow healthy lifestyles. We can allow for early access. We can do more CPR training of lay rescuers. We provide public access to defibrillation services and devices, and recognition of the need for advanced life support. It is important for EMTs to understand cardiovascular structure and function. The heart's job is to pump blood to supply oxygen-enriched red blood cells to the tissues of the body. The heart is divided down the middle into the left and right sides, each with an upper chamber called the atrium to receive incoming blood and a lower chamber called the ventricle to pump outgoing blood. The right side of the heart pumps oxygenated blood to the lungs. The right side of the heart pumps deoxygenated blood to the lungs, and the left side of the heart pumps oxygenated blood to the body, and it is more muscular than the right. Here you have a great picture of the heart showing both the right and left atrium, the right and left ventricles, and the major vessels. So blood leaves each of the 4 chambers of the heart through one-way valves. This keeps the blood moving through the circulatory system in the proper direction. The aorta, the body's main artery, receives blood ejected from the left ventricle and delivers it to all other arteries that supply the body's tissues. Again, as you can see in this picture, this is specific to the vessels. So from the right ventricle, blood goes out the pulmonary arteries to the lung, and then comes back through pulmonary veins to the left side of the heart. The heart's electrical system controls heart rate and coordinates the work of the atria and the ventricles. The heart generates its own electrical impulse starting at the sinus node. The impulse passes from the atria to the ventricles. The cardiac muscle is known as the myocardium. Automaticity allows spontaneous contractions without a stimulus from a nerve source. As long as impulses come from the sinoatrial or SA node, the other myocardial cells will contract when the impulse reaches them. If no impulse arrives, however, the other cells are capable of creating their own impulses and stimulating a contraction. You can see here the SA node located in the right atrium is the primary pacemaker site of the heart. However, there are others. There is the AV node, the bundle of His, the bundle branches, and the Purkinje fibers. So if the SA node fails and the stimulus does not travel along the internodal pathways to the AV node can pick up, or if there's a failure or block at the AV node, then the ventricle can pick up. The autonomic nervous system controls involuntary activities of the body. The ANS has two parts which normally balance one another. We've talked about these before. First, there's the sympathetic nervous system, which is your fight or flight system. It speeds up the heart rate, increases the respiratory rate and depth, dilates blood vessels in the muscles, and constricts blood vessels in the digestive system. In times of stress, this system gains primary control. Then there is the parasympathetic nervous system. It slows various bodily functions down, it slows the heart and respiratory rates, it constricts blood vessels in the muscles, and dilates blood vessels in the digestive system. In times of relaxation, this system gains primary control. The myocardium must have a continuous supply of oxygen and nutrients to pump blood. Increased oxygen demand during periods of physical exertion is supplied by the dilation or widening of coronary arteries. Stroke volume describes the volume of blood ejected with each ventricular contraction. Any increase in stroke volume also results in increased cardiac output. The coronary arteries are blood vessels that supply blood to the heart muscle. They start at the first part of the aorta, just above the aortic valve. The right coronary artery supplies blood to the right ventricle and usually the inferior wall of the left ventricle. The left coronary artery divides into two major branches which both supply the left ventricle. And here, as you can see in this picture, we've now added the coronary arteries to the schematic drawing of the heart. The arteries supply oxygenated blood to different parts of the body. The right and left carotid arteries supply the head and the brain. The subclavian arteries supply the upper extremities. The brachial artery supplies the arms. The radial and ulnar arteries supply the hands, and the right and left iliac arteries supply the groin and pelvis. The right and left femoral arteries supply the legs, and the anterior and posterior tibial and peroneal arteries supply the feet. Arterioles and capillaries are smaller vessels that receive blood from the arteries. Capillaries are 1 cell thick, and they exchange nutrients and oxygen for waste at the cellular level, and they connect arterioles to venules. The venules and veins receive blood from the capillaries. Venules are the smallest branches of the veins, and vena cava return oxygen-poor blood to the heart. They are the major veins. The superior or upper vena cava carries blood from the head to the arms back to the right atrium. The inferior, lower vena cava carries blood from the abdomen, kidneys, and legs back to the right atrium. Blood consists of several types of cells and fluid. Red blood cells carry oxygen and remove carbon dioxide and waste. White blood cells fight infection. Platelets help the blood to clot, and plasma is the fluid that cells float in. Blood pressure is defined as the pressure of circulating blood against artery walls. Systolic blood pressure is the maximum pressure generated by the left ventricle as it contracts. The top number in a blood pressure reading is the systolic blood pressure reading. Your diastolic blood pressure is the pressure that is against the artery walls while the left ventricle is at rest. And that's the bottom number in your blood pressure reading. A pulse is felt when blood passes through an artery during systole. The peripheral pulses are felt in the extremities, for example, the radial artery or the posterior tibial artery. Central pulses are felt near the trunk of the body, for example, the femoral or the carotid arteries. Here in this picture shows you the location points for multiple pulses. Cardiac output is defined as the volume of blood that passes through the heart in 1 minute. This is calculated by multiplying the heart rate by the volume of blood ejected with each contraction, and that's called stroke volume. In the field, stroke volume can be roughly determined by the strength of the patient's pulse. And perfusion is the word that's used to describe the constant flow of oxygenated blood to the tissues. Good perfusion requires the following things. Number 1, the heart must be well functioning. The pump has to work. This allows an appropriate heart rate to allow proper volume of blood circulating. You have to have an adequate volume of blood. If you have reduced volume, for example, through hemorrhage, this limits the amount of tissue that can be perfused. You also must have blood vessels that are appropriately constricted to match the volume of blood available. If the blood vessels dilate, then that actually means reduced perfusion. If perfusion fails, cellular death occurs, and eventually your patient will die. Pathophysiology. Heart-related chest pain usually stems from ischemia, and this is decreased blood flow to the heart or inefficient supply of oxygen and nutrients. Ischemic heart disease involves a decrease in blood flow to one or more portions of the heart muscle. If the blood flow is not restored, tissue dies. Atherosclerosis is a disorder in which calcium and cholesterol build up and form a plaque inside the walls of blood vessels. It can cause complete occlusion or blockage of a coronary artery and other arteries of the body. Fatty material accumulates as a person ages, resulting in the narrowing of the lumen, which is the inside diameter of the artery. The inner wall of the artery will become rough and brittle, and if a brittle plaque develops a crack for unknown reasons, the ragged edge of the crack activates the blood clotting system, which results in a blood clot that will partially or completely block the lumen of the artery. And you can see this here in this picture. And we're going to watch this animation one more time. A thromboembolism is a blood clot that floats through the blood vessels. If it reaches an area too narrow for it to pass, it stops and blocks blood flow at that point. Tissues that are located downstream from the blood clot then suffer from ischemia. If too much time passes before blood flow is resumed, the tissues will die. This sequence of events is known as an acute myocardial infarction or a classic heart attack. Infarction refers to death of tissue. And you have to remember that the death of heart muscle can severely diminish the heart's ability to pump, and this causes cardiac arrest. In the United States, coronary artery disease is the #1 cause of death for men and women. The peak incidence of heart disease is between 40 and 70 years, but it can strike in individuals ranging from their teens to their 90s. Risk factors place a person at higher risk for an MI, and some of those that are major risk factors that can be controlled are cigarette smoking, high blood pressure, elevated cholesterol, elevated blood glucose level or diabetes, lack of exercise, and stress. Some uncontrollable risk factors for acute myocardial infarction include an older age, a family history, and the male sex. However, women are catching up. Acute coronary syndrome, or ACS, describes a group of symptoms caused by myocardial ischemia. These include temporary ischemia resulting in angina pectoris or chest pain, or a more serious condition called an MI or an acute myocardial infarction. Angina occurs when the heart's need for oxygen exceeds the available supply. Usually this occurs during physical or emotional stress. It can result from a spasm of an artery, but it is most often a symptom of atherosclerotic coronary artery disease. It may be triggered by a large meal or sudden fear, and when the increased oxygen demand goes away, the pain will typically go away. Angina pain is typically described as crushing, squeezing, or like somebody is standing on my chest. It is usually felt in the mid-portion of the chest under the sternum. We call this substernal. It can radiate to the jaw, the arms, and frequently to the left arm, to the mid-back, or the epigastrum, which is the upper middle region of the abdomen. Usually it lasts from 3 to 8 minutes, but rarely does it last longer than 15. It may be associated with shortness of breath, nausea, or sweating, and it disappears promptly with rest, supplemental oxygen, or nitroglycerin. Although angina does not usually lead to death or permanent heart damage, it is a warning sign that should be taken very seriously. Unstable angina occurs in response to fewer stimuli than ordinarily required to produce angina. Stable angina responds to rest or nitroglycerin, and there is a skill drill sheet for this because as an EMT you can help administer a patient's own nitroglycerin. Any patient that's experiencing chest pain should always be treated as if they are having an MI. The pain of an acute myocardial infarction signals the actual death of cells in the area of the heart where blood flow is obstructed. Once these cells die, they cannot be revived. They will turn to scar tissue and become a burden to the still beating heart. about 30 minutes after the blood flow is cut off, some heart muscles begin to die. After about 2 hours, as many as half of the cells in the area may be dead, and after 4 to 6 hours, more than 90% of the cells will be dead. By opening the coronary artery with either clot busting, also called thrombolytic drugs, or angioplasty, which is the mechanical clearing of an artery, this can prevent damage if it is done within the first hour after the onset of symptoms. Immediate transport is essential, and it is more likely to occur in the left ventricle as it is more muscular than the right, so it does require more blood and oxygen. Some of the signs and symptoms of an acute myocardial infarction include sudden onset of weakness, nausea, and sweating, chest pain that does not change with your breathing, pain in your lower jaw, your arms, your back, your abdomen, or your neck, an irregular heartbeat or syncope or fainting, and shortness of breath or dyspnea. Some other signs include pink frothy sputum and sudden cardiac death. The pain a patient experiences of AMI is different from the pain of angina in 3 ways, and you need to know these. It may or may not be caused by exertion and can occur at any time, sometimes when a person is sitting quietly or even sleeping. It does not resolve in a few minutes, rather it can last between 30 minutes and several hours. It may or may not be relieved by rest or nitroglycerin. Not all patients who are having an MI experience pain or recognize it when it occurs. When called to a scene where the chief complaint for your patient is chest pain, you must complete a thorough assessment no matter what your patient tells you. The physical findings of an acute myocardial infarction and cardiac compromise include the following. Their general appearance will be frightened. They may be nauseous, vomiting, and have a cold sweat, or their skin may be pale or ashen gray, or cyanotic. Their heart rate may increase in response to pain, stress, fear, or injury to the heart. It may be irregular or slowing due to cardiac rhythm disturbances, or bradycardia due to damage to the inferior part of the heart may occur. Blood pressure may decrease due to diminished cardiac output and left ventricular function. Most AMI patients will have normal to elevated BP. Their respirations are usually normal, and if the patient has congestive heart failure, they may be rapid or labored, and their mental status will change. They will tell you things like, "I think I am going to die." They have overwhelming feelings of impending doom. An AMI can have 3 serious consequences: sudden cardiac death, cardiogenic shock, or congestive heart failure. Arrhythmia, we also use the term dysrhythmia interchangeably, though if you break the word down medically, they do mean 2 different things, refers to heart rhythm abnormalities. Premature ventricular contractions, or PVCs, are extra beats in a damaged ventricle. They're harmless and common among healthy as well as sick people. Tachycardia describes rapid beating of the heart at more than 100 beats per minute. And bradycardia describes unusually slow beating of the heart at 60 or less than 60. The thing to remember is that athletes may have an abnormally or a normally slow heart rate, and folks who are out of shape may have an abnormally high heart rate. The top rhythm strip that you see here is ventricular tachycardia. Ventricular tachycardia describes a very rapid heart rhythm, usually at 150 to 200 beats a minute. It may actually deteriorate into a rhythm called ventricular fibrillation, and that's what you see in rhythm strip number 2 on the bottom. Ventricular fibrillation describes the disorganized, ineffective quivering of the ventricles. No blood is pumped through the body, and the patient usually becomes unconscious within seconds. The process of defibrillation may actually convert this rhythm problem. Defibrillation is the process of shocking the heart with a specialized electrical current to restore normal cardiac rhythm. It can save lives if shocks are delivered within the first few minutes of sudden cardiac death. CPR must be initiated until a defibrillator is available, and chances of survival diminish 10% each minute until defibrillation is accomplished. Asystole is the absence of all heart electrical activity. You see that on the rhythm strip on the bottom of the screen. It usually reflects a long period of ischemia, and nearly all patients with asystole will die. It's very rare for us to be able to resuscitate a patient in this rhythm. Cardiogenic shock occurs when body tissues do not get enough oxygen, causing body organs to malfunction. It is often caused by a heart attack. The heart lacks the power to force enough blood through the circulatory system. It is more common in an AMI, affecting the inferior and posterior regions of the left ventricle, and it is important to recognize shock in its early stages. Congestive heart failure often occurs within the first few days after a heart attack. It develops when increased heart rate and enlargement of the left ventricle no longer make up for decreased heart function, for example, due to the patient having diseased heart valves or chronic hypertension. It is called congestive because lungs become congested with fluid, and this is called pulmonary edema once the heart fails to pump effectively. It occurs suddenly, or it may occur slowly over months. In acute onset CHF, severe pulmonary edema is accompanied by pink frothy sputum and severe dyspnea. And fluid may also collect in other parts of the body. We call this dependent edema or pedal edema, such as in the feet and legs. Hypertensive emergencies involve any systolic blood pressure greater than 160 millimeters of mercury or a rapid increase in the systolic pressure. Sudden severe headache is a common sign, and other symptoms include the following: a strong bounding pulse, ringing in the ears, nausea and vomiting, dizziness, warm skin, which can be either dry or moist, a nosebleed, an altered mental status, sudden development of pulmonary edema. These are all signs and symptoms. Hypertensive emergencies that are left untreated may lead to stroke or dissecting aortic aneurysm. Patients should be transported to the hospital as quickly and as safely as possible. You should consider ALS resources depending on your transport distance and time. An aortic aneurysm describes a weakness in the wall of the aorta. It is susceptible to rupture, and if it ruptures, blood loss will cause the patient to die almost immediately. A dissecting aneurysm occurs when inner layers of the aorta become separated, allowing blood to flow at high pressure between the layers. Uncontrolled hypertension is the primary cause. The signs and symptoms include the following: very sudden chest pain located in the anterior part of the chest or in the back between the shoulder blades. Pain that usually comes on full force from 1 minute to the next. Sometimes a difference in blood pressure between the arms or diminished pulses in the lower extremities occur, and these patients need to be transported quickly and safely as possible. In this table, as you can see, it gives you the comparisons of an AMI versus a dissecting aneurysm. And again, here are the signs and symptoms, and these patients do need to be transported quickly. Patient assessment. As we go through the patient assessment steps, these are always the same: scene size up, primary assessment, history taking, secondary assessment, and reassessment. For scene size up, always ensure that the scene is safe. You need to ensure the scene is safe for you, your partner, your patient, and bystanders. You need to determine the necessary standard precautions and whether you will need additional resources to assist in moving your patients. Determine the mechanism of injury or the nature of the illness. And use information from the dispatcher, clues at the scene, and the comments of family members or bystanders. Primary assessment. Form your general impression. If your patient is unresponsive, evaluate ABCs and assess for AED use. AEDs should always be applied to patients who are pulseless and apneic, and of course we should also apply them to patients who are unresponsive. You want to assess the patient's airway and breathing. If dizziness or fainting has occurred due to cardiac compromise, consider the possibility of a spinal injury from the fall. Assess breathing to determine whether the ailing heart is receiving adequate oxygen. Shortness of breath with no signs of respiratory distress will be common. You should apply oxygen with a non-rebreathing mask at 10 to 15 liters a minute. If they are not breathing or inadequately breathing, apply 100% oxygen with a bag mask device. And if your patients have pulmonary edema, we should use positive pressure ventilation with a BVM or CPAP. Assess the patient's circulation. Check the pulse rate and quality, skin color, moisture and temperature, capillary refill time, and begin treatment for cardiogenic shock early to reduce the workload of the heart. Position the patient sitting up and well supported and manage any signs of bleeding. Make your transport decision. Stabilize the life threats, then determine if immediate transport is necessary. Most patients with chest pain should be transported immediately. Follow your local protocol for determining what receiving facility is most appropriate, for example, the nearest facility or a medical center with specialized capabilities. Determine whether to use the lights and siren for each patient, partially based on estimated transport time. And as a general rule, patients with cardiac problems should be transported in the most gentle, stress-relieving manner possible. Get a history. With history taking, we always investigate the chief complaint. Because of patients experiencing an AMI have different signs and symptoms, you need to seriously consider all complaints of chest pain, shortness of breath, and dizziness. If the patient is having respiratory difficulty, is it due to exertion or related to the patient's position? Is it continuous or does it change, for example, with deep breathing? If the patient has a cough, do they have sputum? Are they producing sputum and coughing it up? Does the patient have nausea and vomiting, fatigue, headache, or palpitations? And ask the patient about any recent traumas. Obtain a sample history from the conscious patient. Use your OPQ-RST mnemonic. As you can see in Table 14-2, this is helpful. Has the patient ever had a heart attack? Has the patient been told that he or she has heart problems? Do they have a history of angina, heart failure, or heart valve disease? Do they have high blood pressure or an aneurysm? Has the patient been told that he or she has other related medical problems? Do they have emphysema or chronic bronchitis? Are they diabetic or do they have other blood sugar problems? Do they have kidney disease? Does the patient have any risk factors for coronary artery disease, such as smoking, high blood pressure, high stress lifestyle, family history of heart disease, or are they taking any current medications? What are your patient's signs and symptoms? Has the patient had the same pain before? What medication does the patient currently take? Do the patient's medications, or does the patient have their medications with them? If so, take them with you to the hospital. Does the patient have, or are they experiencing a heart attack or angina? Is it similar to anything they've had in the past? What allergies does the patient have? Are they, again, what are their medications? Are they prescribed for what conditions, what over-the-counter, or are they using any recreational drugs? Always use your OPQ-RST mnemonic when you're assessing pain. You want to ask about onset, when did it begin, and what caused it. Provocation or palliation, is there anything that makes it better or worse? Is it positional? Does it hurt worse when you're taking a deep breath or when I touch your chest? Have you taken anything for it? Quality, ask what type of pain it is. Let the patient use their own words to describe what is happening. You want to try to avoid supplying the patient with only one option. Do not ask, does it feel like an elephant is sitting on your chest? Instead ask, tell me what it feels like. If the patient doesn't have the ability to answer your open-ended question, then give them a list of alternatives. There are lots of different kinds of pain. Is your pain more like heaviness, pressure, burning, tearing, a dull ache, stabbing, or needle-like? These are all good suggestions for your patient to pick one for what their quality of pain is like. Region and radiation. Ask the patient where the pain is currently and whether it travels to any other part of the body. Severity. Ask the patient to rate the pain on a simple scale. Often, a scaling range from 0 to 10 is used. A 10 represents the worst pain imaginable. Do not use the patient's answer to determine whether the pain has a serious cause. Instead, use it to check whether the pain is getting better or worse. After a few minutes of oxygen or the administration of nitroglycerin, we need to reevaluate pain and get that rating number again to see if there's been any change. Timing. Find out how long the pain lasts, when it is present, and whether it has been intermittent or continuous. Secondary assessment. We need to perform a focused physical exam. We want to focus on the cardiac and respiratory systems. For circulation, we want to evaluate skin color, temperature, and condition. And for respirations, we want to auscultate lung sounds to see if they're clear. We want to see if breath sounds are equal. We want to check for neck veins to see if they're distended, and we want to look at the trachea to see if it's midline or is it deviated. Get a complete set of vital signs. We again evaluate airway breathing and circulation. We get both the systolic and diastolic blood pressures. If available, we can use pulse oximetry to get a reading. And if we have the ability to continuously monitor blood pressure, use it as well. You want to repeat these assessments at appropriate intervals and note the time that each set of vitals is taken. Reassessment. Reassess vital signs every 5 minutes or any time there are significant changes in your patient's condition. Sudden cardiac arrest is always a risk with patients experiencing a cardiovascular emergency. We want to provide interventions, and that will be done with Skill Drill 14-1. Ensure a proper position of comfort. Allow patients to sit up if that's most comfortable for them, and loosen any tight clothing. Give them oxygen. If the patient's dyspnea is mild, use a nasal cannula. If they have more serious respiratory difficulty, use a non-rebreather mask. Patients who are unconscious, we need to assist their breathing, as well as those who are in respiratory distress. We can use the bag mask device or positive pressure ventilations according to local protocols. Depending on your protocol, you may be able to administer low-dose aspirin. The way that aspirin works with patients who are experiencing chest pain is that its effect is it prevents blood clots from forming or getting bigger. We use the 81 milligram chewable tablets, and the recommended dose is 2 to 4 tablets, 162 to 324 milligrams. You may also, by protocol, be able to assist your patient with prescribed nitroglycerin after you obtain permission from medical control. Nitroglycerin's mechanism of action, it relaxes blood vessel wall muscles. It increases blood flow and oxygen supply to the heart. It decreases workload of the heart, and it dilates blood vessels. The side effects may cause a change in the patient's heart rate, maybe tachycardic or bradycardic. The available forms are a sublingual pill or a sublingual spray, and agencies vary in what they carry, and there's also the skin patch applied to the chest. The indications for nitroglycerin are ischemic pain, pulmonary edema, acute angina, or CHF. The contraindications are, after administering nitroglycerins, if the patient's blood pressure is less than 100 millimeters of mercury, do not administer more. If they have a head injury, we should not administer nitroglycerin. If they have used any of the ED drugs, erectile dysfunction medications, such as Levitra, Viagra, or Cialis, in the last 24 hours. Or if they have taken the maximum prescribed dose, which is usually 3. You need to make sure medications are neither expired nor contaminated before you administer them to the patient, and make sure that they are the patient's own medications and not someone else's. And you should always wear gloves when you are administering medications. If cardiac arrest occurs, perform CPR immediately until an AED is available, and reassess your interventions. Provide rapid patient transport if you've not already done this. Communications and documentations. Alert the emergency department about the patient's condition and estimated time of arrival. Report to the hospital while en route the sample history, the OPQ-RST findings, the vital signs, any reassessments, any medications taken, and any heat treatment in the pre-hospital setting. And then adequately and appropriately document your assessments and interventions. Next, we're going to talk about some specifics. We're going to start with heart surgeries and pacemakers. Over the last 20 years, hundreds of thousands of open heart operations were performed to bypass damaged segments of coronary arteries in the heart. If in the coronary artery bypass graft or cabbage operation, a blood vessel from the chest or lung is sewn directly from the aorta to a coronary artery beyond the point of obstruction. For percutaneous transluminal coronary angioplasty, or PTCA, this involves the following steps. A tiny balloon is attached to the end of a long, thin tube. The tube is threaded into the narrowed coronary artery and inflated. The balloon is then deflated and the tube and balloon are removed. Patients who have had bypass procedures may or may not have a long scar on the chest. And you need to treat chest pain in a patient who has had any of these procedures in the same way you do for anyone else. Some patients have cardiac pacemakers. Pacemakers help maintain a regular cardiac rhythm and rate. They are inserted when the electrical system of the heart is so damaged that it cannot function properly. These battery-powered devices deliver an electrical impulse through wires that are in direct contact with the myocardium. The generating unit typically resembles a silver dollar and is usually placed under a heavy muscle or fold of skin in the left upper portion of the chest. EMTs normally do not need to be concerned about problems with pacemakers. When they do not function properly, pacemakers can cause a patient to experience syncope, dizziness, or weakness due to an excessively slow heart rate. The pulse will ordinarily be less than 60. Patients whose pacemakers are malfunctioning should be promptly transported to the emergency department, and if you must apply AED pads, place them 1 inch from the pacemaker in the appropriate positions. Automatic implantable cardiac defibrillators, AICDs, are sometimes used in patients who have survived cardiac arrest due to ventricular fibrillation. These devices continuously monitor the heart rhythm and deliver shocks as needed. Treat these patients like all other patients having an MI, including performing CPR and using an AED if the patient goes into cardiac arrest. The electricity from an AICD is so low that it will have no effect on responders. And do not place AED patches over the pacemaker defibrillator. They again must be placed at least an inch away. Cardiac arrest. Cardiac arrest is the complete cessation of cardiac activity, electrical, mechanical, or both. It is indicated in the field by the absence of a carotid pulse. It was almost always terminal until the advent of CPR and external defibrillation in the 1960s. AEDs involve the use of a small computer, an automated external defibrillator that analyzes electrical signals from the heart. It identifies ventricular fibrillation, and it is extremely accurate, and it administers a shock to the heart when needed. AEDs come in different models. All models require some operator interaction, such as applying the pads or turning on the machine. The operator must push a button to deliver an electrical shock. Most of these use a computer voice synthesizer to advise the EMT which steps to take. The vast majority of AEDs are semi-automated. Shocks may be monophasic or biphasic. Biphasic shock produces more efficient defibrillation and may actually require a lower energy setting. Some of the potential problems associated with AED use include the following. Batteries can potentially die. Check the AED daily and exercise the battery as often as the manufacturer recommends to avoid a dead battery. If the patient is moving, the computer may be unable to tell the difference between electrical signals from the heart and electrical signals from the arms and chest muscles. We only apply the AED to pulseless, unresponsive patients. The computer can become confused by a heart rhythm that is faster than normal, but that should not be shocked. Most computers identify a regular rhythm faster than 150 to 180 as ventricular tachycardia, which should be shock. However, we always follow the steps that the AED tells us to. Some of the advantages of AED use include the following. Quick delivery of an electrical shock. It's easier than performing CPR. There's no need for advanced life support providers. Remote adhesive defibrillator pads, which are safer than paddles, and a larger pad area than paddles, which means that the transmission of electricity is more efficient. Some other considerations. Not all patients in cardiac arrest require an electrical shock. All patients who are in cardiac arrest, however, should be analyzed with an AED. Some of them will not have a shockable rhythm. For example, asystole, which we talked about earlier, or flatline, indicates that there is no electric activity remaining, and PEA, or pulseless electrical activity, usually refers to a state of cardiac arrest despite an organized electrical complex. So basically, there's a rhythm on the monitor, it's an electrical rhythm, but there's no mechanical or pumping of the heart. Early defibrillation is an essential intervention for patients experiencing cardiac arrest. Few patients who experience sudden cardiac arrest outside of a hospital survive unless a rapid sequence of events takes place. The links in the chain of survival include recognition of early warning signs and immediate activation of EMS, immediate bystander CPR, early defibrillation, and early advanced life support. CPR helps patients in cardiac arrest by prolonging the period during which defibrillation can be effective. Rapid defibrillation has successfully resuscitated many patients in cardiac arrest from ventricular fibrillation. Defibrillation works best if it takes place within 2 minutes of the onset of the cardiac arrest. And the training of non-traditional responders in the use of an AED is important. When integrating the AED and CPR into patient care, keep the following things in mind. It is important to work the AED and CPR in sequence. Do not touch the patient while the AED is analyzing the heart rhythm and delivering shocks. CPR must stop while the AED is performing its job. AED maintenance is important. Become familiar with the maintenance procedures required for the brand of AED that your service uses. Read the operator's manual. Document AED failure, which will aid communication with an EMS administrator, the medical director, the media, or a patient's attorney. Make sure the batteries are properly maintained and check your equipment, including your AED, at the beginning of each shift. Ask the manufacturer for a checklist of items that should be checked daily, weekly, or less often. Here's a great example. Report any AED failure that occurs while caring for a patient to the manufacturer and to the U.S. Food and Drug Administration, and follow your local protocol on how you notify these organizations. Medical direction should help you either teach how to use an AED or approve the written protocol for its use. The EMT team and your service's medical director or quality improvement officer should review each incident in which the AED is used. Quality improvement involves both the individuals using AEDs and the responsible EMS managers. Reviews should focus on speed of defibrillation, for example, the time from the call to the time of the shock, and shocks should be delivered within 1 minute. Mandatory continuing education with skill competency review is generally required every 3 to 6 months for EMTs. Emergency medical care for cardiac arrest. When preparing to use an AED, it is your job to make sure the electricity from the AED injures no one. Do not defibrillate patients who are lying in pooled water. Electricity will diffuse through the pooled water. You can defibrillate a soaking wet patient, but you should dry the patient's chest. And do not defibrillate patients who are touching metal. Carefully remove a nitroglycerin patch from a patient's chest and wipe the area with a dry towel before defibrillation to prevent ignition of the patch. It is often helpful to shave a hairy patient's chest before pad placement to increase conductivity. Determine the patient's nature of illness or mechanism of injury. Perform spinal stabilization for trauma patients during the primary assessment, and follow your local protocols for AED use, and this is Skill Drill 14-2. This is an algorithm that gives you the steps to follow.
Cardiac arrest is a condition characterized by an erratic twitching of the heart called ventricular fibrillation.
Hey, buddy, you alright? Hey, buddy. Alright, man?
The best way to restore a normal heartbeat is with an automated external defibrillator, or an AED. This battery-operated device can analyze electrical heart signals, determine when ventricular fibrillation is taking place, and automatically deliver an electrical pulse when needed to shock the heart into its normal rhythmic beat.
Shock advised. Stand clear. Push to shock. Start CPR.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 26, 27, 28, 29, 30.
Follow your local protocols for patient care following the use of an AED. After the AED protocol is completed, one of the following is likely. The pulse is regained, the pulse is not regained, and the AED indicates that no shock is advised. The pulse is not regained, and the AED indicates that a shock is advised. If ALS is responding to the scene, you should stay where you are and continue the sequence of shocks and CPR. If ALS is not responding to the scene and protocols agree, begin transport when one of the following occurs. The patient regains a pulse, 6 to 9 shocks are delivered, or the machine gives 3 consecutive messages separated by 2 minutes of CPR that no shock is advised. Transport considerations. If you perform CPR during transport, it is ideal to have 2 EMTs in the patient compartment while a third drives. Additional shocks may be delivered at the scene or en route with the approval of medical control. AEDs cannot analyze rhythm while the vehicle is in motion and do not defibrillate in a moving ambulance for safety reasons. Come to a complete stop if you need to administer more shocks. Coordinate with ALS personnel according to your local protocols. If the AED is available, do not wait for paramedics to arrive. Notify ALS personnel as soon as possible after you recognize cardiac arrest, and do not delay defibrillation. In summary, the heart is divided into the right and left sides, each with an upper chamber called the atrium and a lower chamber called the ventricle. The aortic valve keeps blood moving through the circulatory system in the proper direction. The heart's electrical system controls heart rate and coordinates the work of the atria and ventricles to pump blood. To supply the myocardium with more oxygen during periods of exertion or stress, the coronary arteries dilate to increase blood flow. The carotid, femoral, brachial, radial, posterior tibial, and dorsalis pedis arteries provide pulses. Coronary artery atherosclerosis is the buildup of cholesterol plaques inside blood vessels that may eventually lead to occlusion, resulting in cardiac compromise. AMI, or heart attack, occurs when heart tissue downstream of a blood clot suffers from a lack of oxygen, and within 30 minutes they begin to die. Angina pain occurs when heart tissues do not receive enough oxygen but are not yet dying. The pain of an AMI is different from the pain of angina. Signs and symptoms of an AMI include crushing chest pain, sudden onset of weakness, nausea, or sweating, sudden arrhythmia, pulmonary edema, and even sudden cardiac death. Sudden cardiac death is one serious consequence of heart attacks, usually from cardiac arrest caused by arrhythmias, for example, tachycardia, bradycardia, ventricular tachycardia, and most commonly ventricular fibrillation. Symptoms of cardiogenic shock caused by heart attack include restlessness, anxiety, pale, clammy skin, increased heart rate, and decreased blood pressure. CHF caused by a heart attack occurs when damaged heart muscles can no longer contract effectively to pump blood. You should treat a patient with CHF by monitoring vital signs, give oxygen via non-rebreathing face mask, and allow the patient to remain sitting up. For patients who are having chest pain, obtain a sample history, follow the OPQ-RST mnemonic assessing pain, get vital signs, and ensure that the patient is in a comfortable position. Administer their prescribed nitroglycerin and oxygen per protocol, and transport. In an unresponsive adult or a child 8 years old or older and who weighs at least 55 pounds, depending on your local protocol, perform AED defibrillation. In an unresponsive child younger than 8 who weighs less than 55 pounds, or depending on your local protocol, perform AED with special pediatric pads. If you do not have special pediatric pads, you may use adult pads. In the unresponsive infant, begin CPR. The 3 most common errors in using certain AEDs are failure to keep a charged battery in the machine, applying the AED to moving or squirming patient, and applying the AED to a responsive patient with a rapid heart rate. Do not touch the patient while an AED is analyzing the heart rhythm or delivering shocks. Effective CPR and early AED use are critical for cardiac arrest patient survival. The chain of survival includes recognition of early warning signs and immediate activation of EMS, immediate CPR from bystanders, early defibrillation, and early advanced care. Seconds count at every stage in the chain. If you have questions, please be sure to bring them to class to ask your instructor and review your case studies. I will also be posting the skill drill PowerPoint and the skill drill sheets on the website on D2L. Thank you.